Yes, thank you very much for inviting me for chapter IVUS chapter. So this is my case. This is the 76 years old woman admitted to our hospitals because of severe chest pain. And this patient has hypertension and stable coronary artery disease with medication every day. And also she has the diabetes mellitus. And this is the plus test on admission. We have the renal function is okay. Troponin is was elevated a little bit, and we have the good HbA1c. And the ECG at on admission, it look normal. This is the chest X-ray. Is also no significant anomalies. And this is the echocardiography, no abnormal commotion. And this is the diagnosis of the patient. We have the unstable angina, high risk unstable angina, and in the patient with hypertension and diabetes mellitus. And we took the patient to the cath lab, and this is the left side angiogram. You see the left side angiogram. We have the moderate calcified lesion in the proximal extended to the mid LAD, and we also see some haziness in the middle, maybe thrombus or calcified lesion in the mid RCA. And at that time we check the IVUS. This is the IVUS for LAD in the left hand side, and this is the IVUS for RCA in the right hand side.
Yeah, so let's talk one by one. LAD, you see the vessel size is 1 to 3.5, and calcium is here is a little bit circumferential, but in general, yeah, just play the LAD. The calcium is not contiguous for the most, and majority was deep. And even this one is calcium is 90 degree, but only one place we see very focal close to circumference, but most of the calcium is not too much. So that's IVUS findings.
All right, please proceed, okay. Dr. Vu.
And because the LAD lesion is more significant than the RCA lesion, we put a stent. We use a balloon, NC balloon, and after that we put a very long stent, 48 by 30 by 48 for the LAD stent. You see the final result is a very good result from the at the final. And 3 days later, 3 days after the LAD stenting, we took the patient to the cath lab again, and we take the angiogram and prepare the lesion for the RCA intervention. Akiko, please help us to comment about the IVUS finding.
Sure. I think whenever you see this type of the haziness, you have to have two differential diagnoses, either thrombus or calcified nodule, which looks like calcium. Already we are start seeing here. But still, this is not a lesion. Luma is big. And then we look for the place. There is some haziness. And starting at the 9 o'clock and coming here, not yet. But calcium is okay for now. And that's the place which we see the haziness. So it's quick, but it's, again, typical calcified nodule. And the calcified nodule is very frequent in the mid-right coronary artery, and next is the left main bifurcation. So it's really typical. This patient already didn't have the calcified nodule, but had being the calcified nodule on the right coronary artery, which is really consistent to what we know in the literature.
All right. Before we move, Dr. Vu, let me ask Dr. Amir now. Amir, so what do you think if you deal with this situation? So what is your strategy after seeing the calcified nodule on the proximal of the RCA?
Yes, thank you. So I think before we went to IVUS, I think seeing this RCA with a defect in the proximal part, it's a filling defect. with no, let's say, acute coronary syndrome involving the RCA, I think we are quite sure that this is probably not thrombus, but it's more like calcium. And seeing this IVUS and the calcium protruding to the lumen, which is Professor Akiko mentioned that it is confirmed this is calcific nodules. I think the way to go is, of course, to deal with some kind of atherectomy, whether it is rotational atherectomy or orbital atherectomy. So I think, although this is quite short, but I think I don't think the balloon-based atherectomy is enough for this. I think we need a rotablation or orbital atherectomy to do. Thank you.
All right. Okay. Thank you.
I think it's a culprit lesion is RAD. I think it's RCA is a non-culprit lesion, and which is the area is quite nice. So I think is a physiology assessment is the one of option.
Okay, great comment. This is also my question, because it looked like MLA is not so tight, but anything we want to intervene this kind of lesion, right? So I don't know whether it's very popular or not. So Juan, is this do you do physiology in this kind of situation?
So
Juan,
in this
Singapore?
case,
since I mean, looking at angiographically, I probably would have gone ahead to treat, but looking at the IVUS may well be, because quite often I'm pleasantly surprised by physiology when you do FFR and things for the RCA in particular. Tight 80% lesions may give FFR 0.85. So yes, I think possible, right. But I probably yes.
All right, but anyway, so Dr. Vu, have planned to intervene this kind of situation. So okay, let's proceed, Dr. Vu, please.
Okay, before going, can you show one more time IVUS? I think there is one important thing. Just play the IVUS for the right coronary artery. So if you decide to treat this right coronary artery by rotablator, you would know where your wire biases go. So IVUS location is really tells you where the wires is go. So if you come to the calcified nodule, you remember coming soon, where the IVUS and wire location, coming soon. Yeah. So you see actually the true calcified nodule is, that's one, right? So really the wire location is on the top of the calcified nodule. So this is really good sign. Your wire or rotablator may go to the top of the calcified nodule. That's it.
Great comment. Please, Dr. Vu.
Yes, because of calcified nodule, and we want to do the PCI in this case, so we prepare the rotaplator. This is the rotaplator Y, rota Y floppy, BER 2.0, because we measure the minimal lumen area is about 1.7. So we choose the BER 2.0 and speed about 160,000. And this is the IVUS finding after we try some rota run. In the left hand side is a run, and in the right hand side you can see the. Please, Akiko, please comment about the IVUS finding after the first run with rota 2.0.
Yeah, we see this picture almost 3 times today, meaning the nice reverberation, and also the calcified nodule was convex shape, but now concave. And you see same pattern again. So that's the place where the rotablator polish. So that's indicating you debug and polishing the surface because of the nice reverberation.
So after the first run with speed 160,000, we think the lumen area of the RCA is good, but I want to make a bigger lumen for the RCA at the calcified nodule. We reduce the speed a little bit from 160,000 to 140,000, and we after that we check the IVUS again. Yeah.
This is really impressive, meaning that you see the many calcium has gone. again, you see that something polish surface and reverberation, but now you see much larger, like the cavity. Starting here, you start seeing the, after this calcium, this branch, you see the calcified nodule segment. It's coming soon. That's a place you see the concave shape and almost like nodule disappear. Oh, I'm sorry, here. That's you see the polish. Yep. So better ablation.
Can I comment to Dr. Vu?
Please, please.
Yes, yes, Dr. Vu, because I think this is a very big RCA, very dominant. Do you do some time of preemptive like pacemaker for this patient? Because I think the risk of bradyarrhythmia is quite high. But the other thing, I think there are a few case series regarding how to handle this to prevent the bradyarrhythmia. Is some expert practicing by not putting the temporary pacemaker, but they're using the aminophylline IV, let's say 200 to 300 milligram, just to prevent the bradyarrhythmia. What do you think?
Thank you for very good question about the temporary pacemaker. In our center, at the beginning, when we run the rota later, we usually use a temporary pacemaker for the RCA rota run. But after for a long time, when we have more experience about the rota ablation, we seldom use the temporary pacemaker for the rota run, except in the case of the patient very high risk rota later. For example, with the patient very low ejection fraction, for the very high risk patient, we put a temporary pacemaker. For this patient, the EF is okay, everything is okay, so we never use the temporary pacemaker in this patient. And sometimes when we use rota run, we use a long run when we check if we have a long run, the risk of bradycardia is higher than the short run. So in our center, we use a long run first, and we see the rate, heart rate of the patient, and if no bradycardia, we still have the long run. But if we have the bradycardia, we reduce the time of the rota run for example 20 seconds or something like that.
Great. Please proceed, Dr. Vu.
So this is the rota effect by IVUS finding. In the left-hand side, you see at the beginning before the rota run. And in the right-hand side, you see the rota effect after some first run with 160,000 speed. And in this slide, you see compare the high speed rota run and low speed rota run. We have the bigger debulking for the calcified nodule. And this is the final results of we put a stent for the RCA in the IVUS finding. And this is you can see the picture, this picture from Akiko. He take a picture for me. This is the left-hand side. We see the IVUS finding. We have calcified nodule in the IVUS, and the second picture from the left, we have the 160,000 rota 2.0. We make some debulking, but with the 140,000, we make a bigger bulking. And the last one, we have the stent, very good expansion for the RCA. So for conclusion, I think IVUS is very useful for the PCI in the calcified lesion. We can detect the calcified lesion, also the indicating for rotablation atherectomy. And as Dr. Professor Akiko showed us, the eccentric plaque and the wide bias is very important when we do the rotablation to prevent the complication for the patient. And finally, we can get the optimal result for the patient. So thank you for attending this my case. So any comment from the panelists and
Okay, thank you, Dr. Vu. It's a really great case. We learned so much from your case. Can you back one? Yes, there you go. One slide before conclusion. There you go. So, in this slides, does it mean that you did 140,000 PM first and then 160,000, or is this converted? Because
we have some missing typing here. The first one we have run 160,000.
oh, all right, okay,
So,
okay. So cool. So this was something that's new for me. So great. Okay, that's good. That's good. All right. In your practice, let's say I ask for Anuruk. So Anuruk, so you start with 160,000 or you or more, and then do a polishing afterwards. So what is your daily practice?
So I changed my strategy to do the LOTA to the high speed, low speed concept, because at the low speed, we have the vibrations and have more tissue abrasion with the low speed. But sometimes if you want to penetrate at the beginning, sometimes I use the high speed first to do the track and do the low speed to make it bigger. So after when you do the low speed, you have to face the chance of no refill, because the tissue debris will be very big and it will cause low flow phenomenon very easily. But after I tried this in really long and a really heavy calcification lesion like this, I always impressive of this technique because it helped me like this picture. It's caused a bigger lumen and it's more easily to crack after I use the scoring balloon and make a better expansion. But last year, I saw the paper that they do the same compared high speed and low speed in Japan. They said the expansion of the stent is the same, but I still like this technique for my practice. If I want to see, if I face the slow flow, I try to use the adenosine intracoronary injection during the procedure to make the flow better before doing the next one. This is my key techniques.
Do you do a cocktail thing before you do rotablator?
No,
okay,
just only the routine things.
What about Dr. Sugi?
All
right. Okay, just one by one. Maybe Dr. Sugi first. Sorry, Gautam. Okay, Sugi, is there any comment or any other strategy?
This is representative excellent case of the low speed abrasion. So I think it's a very good treatment. We always start about 180,000 RPM, and then the wire bias is favorable, it's confirmed. Then we try relatively low speed, 140 up to 140,000 RPM. But the low speed abrasion has a risk of the unexpected vessel injury. So we have to check the wire bias, or the good indication is the circumferential severe calcification, I think. And another point is low speed abrasion can improve the bradycardia. So in the high speed, the bradycardia occurred, we set a lower speed. It can improve the bradycardia, I think.
Okay, great. Gautam?
I think one of the things that the operator, Dr. Fu, pointed out is it is very important that the runs are short. If the runs are short, you have less adenosine activation and less bradycardia. With longer runs, you tend to have more bradycardia, as with higher RPMs as well. The question that I really wanted to ask the panel of, looks like we have a panel of high calcified lesion operators. But what has been experience? Some of us have had some experience with administering saline flush after each run of atherectomy. What has been your experience with that?
I prefer that because every time I flushing, it means that I push the debris down and check and I always mix the contrast a little bit to check the flow together. That's make me confident to do the next one. It's my tips and tricks that I learned from Dr. Misudo in the last 10 years ago, that he always do the short run and test every time, to check the flow before do the next one.
Good. So, okay, we talk about wire biases a couple of times. So, let's say if we have a wire facing the healthy tissue, so what is your strategy, Gautam? Do you change to the intermediate wire, or you just manipulation the wire to get facing the calcified one?
So wire bias is a difficult issue, especially for calcified nodules. In general, we would then try to generally change to a rotastiff wire, for example, to see if there is a more favorable wire bias with a rotastiff wire. Sometimes, even that does not give you a favorable bias, and you may have to actually maneuver the wire or pull on it gently or advance it gently just before you start the burr going. And that sometimes can help change the bias in the vessel as well. I've had one operator that I do, that I work with, who has also done some work on maneuvering the guide a little bit to kind of help change the wire bias as well. And so really that's a very complex interaction. And you really need to study what is happening. You may need to take some additional angiographic images in different views, especially for these RCA calcified nodules. The right RAO view may sometimes be helpful because you can actually identify the wire against the calcified nodule in the RAO view better sometimes as well. So there's just a whole different variety of tricks that come into play for this.
All right, thank you. Because I saw many perforation, maybe related to this kind of issue, especially for the very tortuous vessel with the eccentric plaque, which is very devastating. But for not very tortuous vessel, let's say with a little bit a straight vessel, and then you have a wire bias, is this also dangerous? Is there any issue in that? Akiko, maybe you can help me. With the calcified nodule, you have a wire bias, but it's not very tortuous vessel, relatively straight vessel. Is this a really issue now?
I
Or should we
don't
change
know.
Okay. All right.
Donny, there is a good questions here from the Q&A chat block. Maybe we can discuss regarding the rewiring in decay crust. There is a decay crust technique for side branch rewiring. OCT looks better in identify the right rewiring. And maybe you guys have some tips and trick how when we are using IVUS. Is there any tips, the right way to do the rewiring? So maybe.
Yeah, that's great. So it's comparing IVUS and OCT, in terms to know your wire is. So I don't know, Akiko, what do you think about that?
I think that I would show. I was in the Dr. Xiaoyan change lab, and then always he do the IVUS after the crushing, before rewiring to the Circ. He always check. No, first he crash and then he wire to the Circ, and then he definitely check the wire location from the LED pullback. And I would like to show my slide if you want. I can explain what I'm talking about.
Please.
Yeah. Yeah. Could you share your slide?
Dr. Fu, yeah.
Okay, so can you see my slide?
Yes.
Or maybe no. Yes?
Yes, we can see it clear.
Okay, so this is actually this is a slide by Dr. Xiaoyan Chen he gave me. And this is the wire location in the circumflex, right? And of course, this pullback from the LED to the left domain. And how you can make this wire location easily by IVUS is when you have the IVUS picture on the console, you see this type of picture. You see like the line, this line can rotate this longitudinal plane. So the first, I recommend to go to okay, let's go to something else. That's not the one which I'm going to show, sorry. Okay, sorry. Okay, yeah, that's a good picture which I'm trying to show. So this is IVUS pullback from the LED to the left domain to check the wire location to the Circ. And how you can confirm is you have to use this longitudinal view. And you see the wire from the left domain to the circumflex is going to the very proximal cell, right? And how you can confirm is open the IVUS picture, and then always you see this line. And then first you look for the wire in the sac very distal portion, because if you come to the close to the bifurcation, there is a strut, and it's very confusing which is the circumflex wire. So I recommend to go to the very distal to find the very clear wire into the Circ. Once you find that wire, you bring this plane to the wire. Once you bring this plane to the circumflex wire, that's and longitudinal plane give you the wire location directly. And then you can see wire is a proximal. Yeah, so rotate the longitudinal view using the console, and then by checking the wire into the Circ. That's it. But this has to be done after the wire, but before ballooning. And if you see the wire is too distal, you can rewire and then check again. That's the tip and trick.
How about when the lesion is calcified? All the lesion are calcified. Is there any impact to knowing the wiring, the position of the wiring?
Are you asking me?
Yes, yes.
I mean, we have to remember where the plaque located is always opposite side to the carina, right? So if there is a calcium, that should be the opposite side of the carina. And then if so, your wire is more likely going to the distal, because opposite side, meaning the proximal side, is the calcium is always located to the opposite side, such as proximal side. So, I mean, I would say if there is a big calcium, it's more likely carina shift and more likely difficult to go to the proximal side for sure. So then you have to think about how to make it better by debugging, etc. Yeah. That's I think by IVUS standpoint.
Thank you.
Right, great.
There is a few data regarding the side branch wiring is confirmed by OCT, but I prefer the OCT actually, but is in daily practice it is not. It is very difficult to confirm the successful distal wiring or proximal wiring by OCT. So I absolutely agree with article. Is a presentation is I think is more IVUS can give is confirm is whether is wiring is proximally or distally when we try to the two stenting in the bifurcation lesion.
I think it's really up to you which you prefer.
Yeah.
OCT expert like OCT, they know more how to see. But I wanted to say IVUS can do very easily as well. That's a point. Yeah.
Okay. Yeah.
For the OCT lover like me, so sometimes it's good to see for the distal, not for the decay crash technique, because in the because we have to use a 3D reconstruction to see the strut. So that's why for the QLOT, for the provisional stent before kissing is good, but for the decay crash, I think IVUS or for the participants, they recommend to use the stent boot or clear stent, the stent enhancing program. This will be very effective to do the decay crash more than the OCT, even though I use a lot of OCT to do the bifurcations. I agree that decay crash is better to use IVUS or stent enhancing technique.
Okay, great points.